Good morning, everyone, and welcome to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. We have some terrific speakers this morning. Before we get started, I just want to say that we want this to be a very interactive and engaging session. So you can participate by joining by web by going to pollev.com and enter DeBakey, or by joining by text. You can text DeBakey to 37607 and then text in your message. So it's my pleasure to introduce my great colleague, Valeria Duarte, who will introduce our speakers.
Thank you, Dr. McGillivray. Today we will be discussing a challenging topic, mechanical circulatory support in patients born with adult congenital heart disease. As you know, most patients born with congenital heart disease survive into adulthood. When they develop advanced heart failure, this presents the providers with many challenges, mainly because of the complex nature of their anatomy, the multi-organ involvement. In all cases, a multidisciplinary team is key for the management. We have two very special speakers who will share their experience with us today. The first one is Dr. Peter Ermis. Welcome, Dr. Ermis. Dr. Ermis was born and raised in Houston. He completed his undergraduate studies at Rice University and graduated medical school in San Antonio, where he first discovered the need for ACHD providers. Dr. Ermis completed a combined residency in internal medicine and pediatrics at Baylor College of Medicine, and he subsequently pursued a combined fellowship in adult and pediatric cardiology at the Texas Heart Institute and at Texas Children's, making him a very unique provider among a few in the country. Dr. Ermis is the medical director of the Adult Congenital Heart Disease Program at Texas Children's. He also leads the Adult Medicine Program and the ACHD Fellowship Program. His research focus is long-term follow-up and outcomes of patients with Fontan circulation. Dr. Ermis, welcome.
And I guess the surgeons will introduce the surgeon.
That's right.
We're very honored to have Dr. Ed Hickey join us with Dr. Ermis. Dr. Hickey is a native of the United Kingdom. He was educated and did his surgical training in Southampton before moving to the New World. He went to Toronto, where he furthered his cardiothoracic surgery education and specializing in pediatric and congenital heart disease. And he stayed there for 15 years. And Dr. Hickey has established himself as one of the leaders in the world in the surgical treatment of patients with, adult patients with congenital heart disease. About a year ago, he moved to Houston at the Texas Children's Hospital and has continued a distinguished career. So we are really honored to have both Dr. Hickey and Dr. Ermis speaking with us this morning. So without further ado, we'll hand it over to our colleagues at Texas Children's.
Thank you, Dr. McGillivray and Dr. Duarte. Thank you all for allowing us this morning to talk with you. Can you just all see my pictures just to make sure?
Yes.
Okay.
Yes.
Okay, perfect. Well, thank you. So we'll be talking about a very challenging topic, as Dr. Duarte mentioned, mechanical support in ACHD patients. As you saw on the previous slide, neither of us have any interests to report. So just in the beginning, we'll discuss some epidemiology as associated with ACHD and heart failure, and just really kind of look at some logistical challenges and barriers that are often encountered in treating these heart failure patients that are very different than those that's seen in the acquired cardiac patient. And then look for, when do we decide when to pursue mechanical circulatory support in these patients? And then we'll spend, the rest of the time talking about how to pursue it and what we decide and how to manage those patients. So heart failure in our ACHD patients can present in many, many different ways. It can present as a patient here who is in his late 30s who is a history of transposition of the great arteries, who has a history of an atrial switch procedure. You can see kind of a classic presentation where the intraventricular septum is bowed over to the left side, and you see this big globular, severely depressed systemic right ventricle. Here's another patient with transposition with an atrial switch. This seems to be make up a large amount of our patients. Here you can see that it's not as severe as appearance as our previous patient, but this patient actually had much more symptoms related to the heart failure than the previous patient, which kind of goes to show you is sometimes the imaging doesn't speak to the severity of heart failure that a patient may have, and that's what may become very tricky in these patients, is that you have to take many different aspects of the patient in mind in deciding, who may need advanced therapies. Or you have this patient. This is a patient who was in his mid-30s with a single ventricle Fontana history of a DKS. You can't really see all that here, obviously, but you can see his function is not too bad, but he has a severely failing Fontan. He was an atrial pulmonary Fontan, and you can see just the tremendous stasis within the Fontan circulation. He had actually suffered through significant pulmonary emboli at the time of this. So these are all types of different varieties of patients with heart failure, and all types of different varieties of patients that we have to make decisions of how to pursue advanced heart failure therapies. And as Dr. Duarte mentioned, we're here because of successes. This is a graph looking at cohorts of birth, and this is just survival of 1 year. And so if you're born in the 40s and 50s, most of these kids didn't live to 1 year of age, much less live to adulthood. Due to tremendous technical, surgical, and medical advances, that story has changed. You can see with the advent of cardiopulmonary bypass in the 60s and 70s, and then with further advances into the 80s, 90s, and more modern time, that it really has become more of a rule for patients to survive to adulthood, except for the most complex forms of congenital heart disease, and live to adulthood and live much, much longer lives than we previously had seen in these patients. And thus, that's given us this increase of adults in the United States with congenital heart disease. In 1970, there were roughly about 300,000 adults with congenital heart disease in the United States. That number is now estimated to be over 1.6 million. And if you look at just general population growth estimates, this is looking just at static prevalence. That number will grow to approaching 2 million, probably in the next 10 to 20 years. And not just the United States. We practice more locally. So in the state of Texas, there's estimated to be over 130,000 adults currently with congenital heart disease. And in the Houston metro area, estimated to be over 30,000 adults with congenital heart disease. But a good number of these patients may have relatively simple diseases, and so they may not approach the need for advanced heart failure therapies. Mainly, it may be the moderate or complex patients that we see in our practice. And this just looks at those patients with severely complex disease. So those single ventricle patients, transposition of the great arteries. And so you see that currently in the United States, there's approaching 200,000 of these most severely complex patients, those patients that, even today, not all live to adulthood. And in Texas, approaching 15,000. And even just in the Houston greater metro area alone, about 3,500. So if you take these severely complex patients and then overlay the moderately complex patients on top of that, we get numbers that are probably about 4 or 5 times these numbers of those patients that really do have a high potential to develop heart failure over the course of their lifetime. And a difficulty in having enough providers and enough care places to manage these patients. These are just the 35 accredited ACHA, ACHD programs in the country currently. And we know that about less than 4% of those patients with adults with congenital heart disease receive care currently in one of those 35 accredited centers. And so we need to collaborate with all centers across the United States, big and small, to take care of these patients and meet them where they are, and look to recognize when do we need to advance therapies, when do we need to advance who's caring for these patients. Because heart failure in these patients is difficult to deal with. And just to touch on that, we'll want to touch on just a few things and aspects related to heart failure. One is just even coming up with a definition of heart failure in these patients is oftentimes problematic. There's been, a whole host of publications actually looking at this. This is just a summary table from one of those publications looking at the many different definitions that people have given from heart failure, and I'll just point out a couple. And so, Dr. Stout, looked at, is a syndrome characterized by either pulmonary or systemic venous congestion or inadequate oxygenation. Dr. Law was signs and symptoms of heart failure requiring medical therapy with either decreased systolic or significant dysfunction of AV valves. Of course, then, at its most simplest form, and I may have a bias to this final definition, is just an easy thing. All adults with CHD have heart failure. That probably is not true completely, but I think there's a lot of truth in that statement over even some of the other definitions, because you do have to have a high index of suspicion because there are some adults who wouldn't fall into either of the previous two definitions that I discussed that have heart failure and are being missed because we're not working them up in that way. And so we have to look for, well, in those patients that have heart failure, what are their predictions of that heart failure progressing? And there's a lot of different, literature out there. I think simplistically what we have found is most things that we have utilized in the acquired patient population is not as useful in our adult patients. And so, like I've said before, you have to have a high index of suspicion. This paper by Dr. Morelli and team just from last year looked at it and looked at a whole host of predictors and actually found the only things that really were in multiple studies to fall out were what their underlying CHD classification is. So really finding that those patients with moderate or severely complex forms of CHD would have a higher incidence of heart failure. And then looking at BNP or renal function in those patients. Some of the more other common things that we see in the acquired populations, such as NYHA class, systolic or diastolic dysfunction, or other laboratory markers did not fall out across publications as far as predictors of impending heart failure. In general, though, I think what we have found consistently in the literature, those patients who are more complex are more likely to develop heart failure. And in reality, for those moderate or complex CHD patients, heart failure, along with probably arrhythmia, becomes in combination a final common pathway oftentimes for these patients. You see, in a typical moderate to complex patient, they'll typically many times develop arrhythmias as a progression to late stage failure. But approximately 42% of ACHD patients have moderate or severely complex disease. And that means there is a large number of these CHD patients. If we say there's overall 1.6 million in the United States, a large number who are at high risk for developing heart failure. And we need to come up with mechanisms and support systems to help take care of and address this problem. Looking at a little bit more, this was a paper that was published a couple years ago showing that different underlying anatomies had different risks for heart failure. Obviously, as we would all think and all know, that we see that these patients with systemic right ventricles tend to develop and do more poorly from a heart failure perspective long term. And these are just increasing probabilities of developing heart failure by age, given different subsets of underlying anatomic diagnosis. And see those things that we actually see in practice are single ventricles, tetralogy of Fallot patients, and atrial switch transposition patients, who are all easily classified as moderate or severely complex, have a much higher incidence of heart failure than those patients with more simplistic disease or underlying anatomy or physiology. And we've seen this as we increase survival, just like we saw, decades ago, as we increased survival in those patients with underlying coronary disease, we saw an influx of heart failure diagnosis. We've seen the same thing with our ACHD patients, and we're currently seeing that as we've increased survival in these patients, especially survival in those patients with more complex anatomies. We're seeing additional diagnoses increasing for heart failure. This is just showing, in the early 21st century and up until 2011, increasing ACHD heart failure hospitalizations across the United States. And then additionally showing that in ACHD patients, if you have a heart failure associated with a hospitalization, you have 3 to 4 times risk of death associated shortly after that hospitalization compared to those patients who are hospitalized without heart failure as a part of that admitting diagnosis. I'm not going to spend a lot of time on this because this really you could talk about for a long time is all of the different underlying anatomies that exist within ACHD and congenital heart disease drive different forms of heart failure. And that's what makes it so difficult to recognize, so difficult to treat. But I think you have to be able to realize that the anatomy drives the phenotype that you're going to see. So there's patients who have LV obstruction. They may be biventricular patients and have pressure overload. There's those volume overloaded patients that may be more typical that we see in the acquired population. And so you can manage them relatively similarly. But draw attention to the 2 bottom ones. Systemic right ventricles and then single ventricle Fontans are drastically different oftentimes than our patients that we see typically in the acquired adult heart failure community. And also the medications options for them and their response to the underlying medical therapies is vastly decreased because of their anatomy. This is just additionally just shows some other predictors besides CHD classification. There is some studies that show that symptoms and NOAH functional class can be a predictor as far as those patients that are leading down the heart failure pathway. I've mentioned BNP that fell out in Dr. Morelli's study as well. You can see this study used to cut off in regular BNP of greater than 164. The one thing to BNP of greater than 164 here in this study. The one thing to note about NOAH functional class is it can be very tricky in these patients. This is actually a graph from an article. This was probably over a decade ago with Dr. Shaddy and Dr. Webb, but this is all showing, these are all peak VO2s measured in patients who all were asymptomatic, all were classified as NOAH class 1. And that's where we find difficulties in looking at symptoms in our patient population, because we've all had patients who said, yeah, I feel fine. I can do everything I want. I do exercise. And then you put them on a treadmill and they have a peak VO2 of 12. And you're like, well, how does that all kind of jive together? And it's really because their exercise is just kind of getting up and walking leisurely around, and they've accustomed to what they feel. And to that, it feels normal. But they really, really are suffering from their underlying anatomy and physiology. And so when we look at factors and look at what we can look at as far as worsening clinical signs, you can use multiple different things. And I think you have to use almost all of them to form a perfect picture for these patients to help you make some predictions. So exercise testing is valuable. Single point in time testing may not be as valuable because these patients all have depressed exercise function even at their best. And so looking at serial exercise testing, so declines in peak VO2s during consecutive CPETs have shown to be, poor predictors in patients, especially those with underlying at-risk physiologies. Those patients who, remember, as I mentioned, functional class can be helpful, but patients will often overestimate their physical function. I think this is a key, and I think sometimes we overlook this. A patient who has a heart failure hospitalization automatically has an increased risk of mortality during the subsequent 1 and 3 year period. And so that first heart failure hospitalization should raise flags to get these patients in an advanced heart failure pathway. Arrhythmias, besides heart failure, arrhythmias is the final common pathway for many of these patients, and oftentimes arrhythmias lead to heart failure. And so aggressively treating these arrhythmias with medications and interventions is important. Looking at BNPs, the risk of death is in heart failure is low in those that are normal and consecutively stable. But if you see them raising up, even if it is to a mild proportion, that should give you the underlying risk. And as I mentioned previously, renal function needs to raise red flags. You can use some of the other parameters that we can use in CRP, liver disease, red cell distribution, sodiums. they're not as across the board predictive, but in certain patients, they can be valuable. The one thing that I know Dr. Duarte mentioned in her brief introduction is you need a team to take care of these patients. And so these patients are vastly complicated, and you need every single part of this team to be on board with focusing on taking care of these patients and thinking through them with a congenital heart disease lens before you even move down the pathway of deciding whether you're going to do advanced heart failure therapies and mechanical support. And you really need, especially when getting into these, high risk advanced therapies, you need, systems and locations that are useful. There's no data looking at it specifically for mechanical circulatory support, but there was a recent article last year looking at it in transplant patients and showed obviously that those patients who did better in higher volume centers and ACHD or ACHA accredited centers. But there is conflicting, it does conflict in a way in that, in some centers, it was, well, you did better at a children's hospital on the wait list mortality, but worse, maybe, as the outcomes, at 1 year. And I think part of this has to do with there's not many centers out there taking care of these patients. So it's difficult to get data on that. So really need to work, trying to get registries in place and data to move forward with that. Overall, I think it's important to have a system. You need to get these patients in a pathway, and you need to have that pathway be able to keep track of these patients and aggressively treat these patients. Otherwise, you'll lose them or they'll decline before you can properly address their issues. And so you really do have to, you want to be aggressive in managing them. You want to get hemodynamics. You want to make sure there's no rhythm issues you need to take care of. You want to do your best to treat them with medical therapy, although that's oftentimes difficult. You want to reassess them constantly, and you want to have close follow-up and be ready to refer for advanced therapies as soon as you feel that that's a need. Just one moment about medical therapy. Medical therapy can be useful, but oftentimes in these patients, we're often treating their rhythms and we're treating their volume with diuresis. A lot of times these, just baseline remodeling medications, use of an ACE inhibitor and systemic RVs is just not helpful. And we really do need to explore whether we can find some better medical agents for these patients because we don't have a lot of great options that exist in our moderate and complex patients. From a heart failure standpoint, once you start, you sort of, oftentimes we'll see these patients continue that decline. And arrhythmias, hospitalizations, as I mentioned previously, can really signify that decline. And so, there's a study from many years ago. And so if you're a 40-year-old Fontan patient, you basically have the same 5-year risk of death as a 75-year-old. And so you can't let their age throw you off in that these patients are really, well, from a clinical risk standpoint, well above their stated age. And so just the final couple minutes about, considerations of when we think about mechanical support in these patients. You really do have to take a comprehensive team approach with a formalized pathway. You want to, you want to plug these patients in really early on, even before their first hospitalization with heart failure, but immediately after their first hospitalization. And the keys to this is frequent check-ins and serial measurements of predictors that we had mentioned, BNP, renal dysfunction, because you want to be proactive, not reactive. You want to preempt management and not just respond to their failure. From a medical optimization standpoint, you want to try to do what you can do, but sometimes that's not always can work. Like I said, from a medication therapy, you're mainly managing fluids because of the difficulties in some of the medications. But you do need to get these patients in a cardiac rehab and exercise program. Exercise prescriptions in these patients are valuable where you can get them in better functional status leading up to any advanced therapies, but they actually improve their underlying symptoms with these programs. You want to electrically optimize them, aggressive rhythm control, restoring those patients to chronotropic competence who are not. And then you want to look at any surgical interventions or structural interventions you can have, whether it's a valve replacement that you can do in the cath lab or surgery such as a Fontan revision or something of that sort. And then you want to address these patients at the right time. You don't want to be too late, which we often are because the patient may fool us. They're feeling well. They don't want anything. You don't want to be too soon, obviously, because these are, have risks involved. So you want to use objective data, and you need to get a lot of data. So utilizing serial labs, objectively measuring serial CPETs, and looking at what their hospitalizations are very important in looking at how to proceed with these patients. Because you have different mechanisms of how you can proceed. There's not a lot of data out there in how to proceed, but there is data to show that mechanical circulatory support is an option for these patients. And it's an option not only to bridge patients to transplant, but it's an option for destination therapy, and you know those patients that aren't transplant candidates. And so I'm going to turn things over to my colleague, Dr. Hickey, and he's going to pick things up and continue on talking about these patients.
Good morning, everybody. So my single biggest professional gripe is that premature heart failure is an inevitable consequence for so many complex congenital heart lesions, and yet these young adults have a disproportionately poor access to advanced therapies, whether it's mechanical support or indeed transplantation. And programs are very reluctant to embark on these mechanical support or transplant options because of the perceived risk involved. And so many large ACHD programs have instead invested in building robust palliative care programs to manage these patients as they decline through their heart failure. And it's because these young adults, they look, feel, and behave so differently from heart failure patients in the non-congenital world. They're much younger. Their medical therapies are much less proven. In fact, many medical therapies established for other forms of heart failure simply have no data supporting their use in ACHD patients. In ACHD, the heart failure really does affect every single non-cardiac organ. The reserve of all of these end organs is dramatically reduced. Take, for example, Fontan-associated liver disease, which looks awful, and it creates a great deal of anxiety and concern when these patients are assessed, and often presents as a big obstacle to accepting for VADs or transplantation. And yet, in my experience, it's actually very rare that it leads to very problematic perioperative problems. And yet, on the other hand, intrapulmonary AVMs or collaterals can often be overlooked and yet can present as extremely big challenges to manage in the early perioperative period. Putting this all together, these patients represent very, very challenging transplant candidates and also VAD candidates for all of these reasons. And so many programs have been reluctant to take them on. In Toronto, it was really no different, where my previous home was until last year. This is transplant data in adult congenital patients, and up until about 2013, outcomes were really very concerning. Mortality was high, high to the level where, to be frank, it jeopardized the integrity of programs. Programs were very reluctant to accept this risk tolerance and accept patients for transplantation. And yet you can modify this. Around 2013, 2014, we really focused on how we could change the journey of these patients through transplantation. And since that time period, we dramatically improved transplantation outcomes to the extent that early mortality was about 6%, which was completely comparable to the non-congenital adults undergoing transplantation at that center. Completely equivalent outcomes despite the added complexity of these patients. And this is important because if patients are not accepted for these advanced therapies, then they unfortunately die whilst waiting. It's also important because if you can get these patients through early transplantation, they actually have the best long-term outcome, the best bang for the buck, or the best return for the investment of that donor organ. The median survival for ACHD patients who get through that initial perioperative period is 20 years. That is absolutely extraordinary. It's much better than most people perceive it to be, and that's compared to about 14-year median survival for example, dilated cardiomyopathy on this conditional survival plot. For me, it's all about putting in place the right team. It's having the right people, the right skill set, etc. My partner in crime in Toronto was Lucy Roach, a very good heart failure cardiologist who epitomized the concept of really owning patients and their problems, leading them through their heart failure rather than following them. And the rewards are huge, and getting these patients through is exceptionally gratifying, whether it's through mechanical support or transplantation. But transplantation isn't always the answer, and the mustard conundrum really illustrates that nicely. The mustard operation is the old form of repair for transposition of the great arteries, a lethal congenital heart lesion, where you reverse the left and right atrial flows. And it was very successful. Many thousands have been done around the world with very low mortality. This is Maria, who was actually the first ever mustard operation, 1963. She's still alive. That is Bill Mustard wining and dining her literally on her 16th birthday. And but there's a problem with this. The problem is that after a mustard, your systemic ventricle is actually your right ventricle, and your systemic AV valve is your tricuspid valve, and both are destined to fail in this systemic role. They will fail. When they do fail, the problem is that the silent hidden problem is that the pulmonary artery pressures are often significantly elevated. You cath them, and it's not uncommon to find PA pressures of 70 or 80. And of course, transplantation is completely off the table, particularly given the overall complexity of these patients. And given that VAD therapies have been utilized in this scenario where you have secondary pulmonary hypertension, it's logical that it might be helpful in situations where you have a subaortic or systemic right ventricle that's failing. And so at that time, this is quite old data. This is data at the time when we started doing it in Toronto. The Newcastle group, who we had close links with, Asif Hassan and David Crossland, had already started doing subaortic RVADs in these failing mustard patients and had pretty encouraging success. Of the first 6 they did, 4 got to transplant candidacy, and we were encouraged by that. And so using their experience and help and guidance, we did 5 in Toronto, and all 5 became transplant eligible, proving the concept that you can get the PA pressures down and get these patients to a transplant eligible window. And so here at Texas, we've done 3 in the last 9 months in these subaortic RVADs, all are home. 1 is currently being discussed for transplant candidacy. 2 are home and independent and are rehabilitating. They're very unlikely to be transplant candidates and will be destination mainly due to comorbidities. So putting that together, over 70% of these patients with failing mustard physiology and very high PA pressures became transplant eligible. And if these additional 2 patients show that their PA pressures come down, then that's almost 86%. So it is a very effective strategy in reducing the PA pressures and bridging to transplant candidacy. Just a few weeks ago, in terms of durable support as a whole, we just submitted an abstract to the ISHLT, and I obviously can't elaborate in any great detail, but I will, just to summarize, these are pretty complex patient cohort of about a quarter single ventricle and half subaortic RVADs with really very good survival to hospital discharge. A recent patient of ours illustrates, I think, some of the complexities that these durable VADs can offer, particularly in the subaortic right ventricular situation. This is a 57-year-old who had failing mustard physiology and presented really in absolute extremis over the course of this last 9 months, very high BNPs, had already had a VT arrest at home, which thankfully self-aborted before CPR had to be implemented, and came in very cachectic with a host of comorbidities, the worst of which was really severe restrictive lung disease, which is a phenomenon that many adult congenital patients manifest, as well as a chronically paralyzed right hemidiaphragm. And he had absolutely no options, very, very symptomatic. And so despite his high risk, we implanted a HeartMate 3, and almost immediately his recovery was dramatically improved. I guess it proves the concept of having a robust cardiac output is good for you. Almost immediately he was transformed. Yes, he had a lengthy in-hospital recuperation as one might expect, but he's now at home and continuing with his rehabilitation. Several key aspects of the recovery I think are worth highlighting. The first is early extubation. In fact, he was extubated in the operating room. He failed, had to be reintubated, but was extubated just a few hours later. And I think that's a key message both for high-risk transplants like this and these high-risk VAD patients. Getting them extubated, i.e. off fentanyl, off benzodiazepines, and off the vasoactives which go with these sedatives, I think is a major factor in expediting their progress and preventing perioperative delirium and the multi-organ failure that can then ensue. These are pretty challenging technical transplants. They're often high-risk re-entries. This one wasn't too bad, but the anterior aorta you need to watch out for, and don't underestimate the right atrium. Of course, it's a systemic atrium, and even the smallest tear in it can lead to air embolism and catastrophic stroke. Once we're inside through that the re-entry, which is a very important re-entry, I tend to try to minimize dissection if possible. And in these mustard VADs, it is usually possible to do that because the aorta is anterior, the systemic ventricle is anterior. And in this case, for example, I just used femoral venous drainage, thereby I didn't have to dig out the SVC or IVC and cannulate the anterior aorta. In terms of cross clamp, just like most VADs, we do a beating heart without a cross clamp. The positioning of the VAD can be very unusual because of the orientation of the ventricles. And in my experience, the VAD either goes quite near the midline on the diaphragmatic surface or directly anterior into the free wall of the right ventricle, which is a very odd position. And I've used both orientations and both have been fine without any inflow obstruction. We use TEE with our finger, locating our finger on, using our finger to identify areas of the ventricle that potentially you might want to place the inflow cannula. And then an epicardial probe is very helpful once you've decided to make absolutely sure there are no papillary muscles there. It's often close to the AV groove, but the tricuspid annulus the tricuspid apparatus is actually rarely a problem. And in these muscularized right ventricles, you can cut away a lot of muscle to make sure the inflow is not obstructed. Meticulous hemostasis is absolutely key, and especially so if you're going to proceed with early extubation, which I almost always try to. We now use bivalirudin for managing these VADs prior to warfarinization. And the rehabilitation is, of course, absolutely essential. And that's not just physical, but things like nutrition and also pre-conditioning with nutrition if you have time in these patients. This just shows the location in this last one. This is the inflow cannula here. And it is close to the AV groove. But as I said, I've never had an issue with it interfering with the tricuspid apparatus. And this is another example showing that very anterior position sometimes that you have to instead adopt, which again has not been problematic in my view. This is the cranial end of the patient, the feet are down here, and this is the surgeon's side. So this is diaphragm here. So that's durable support. What about sort of medium-term support? And we've started using Impellas in adults, in these adults with congenital heart disease. And I must say, up until a year ago, I was pretty skeptical, and I'm increasingly becoming enthused with the idea. I'm becoming very impressed with it. A recent example could illustrate that. This is a 24-year-old with right atrial isomerism and heterotaxy with dextrocardia, had failing Fontan physiology, an extracardiac Fontan, which you can see on the left side of the body here, which then courses over to the right dextrocardia and a right aortic arch. And he had severe AV valve regurgitation with intermittent admissions for decompensated Fontan failure. And his natural history with this ongoing severe AVVR was bleak. He's a very high risk overall candidate with tenuous end organs, but we embarked on an AV valve replacement with VAD backup, and initially he did remarkably well. In that first week, in fact, he really flew. Again, we extubated him in the operating room and continued to de-escalate, weaning inotropes and gradually introducing oral heart failure medications. He was in heart block, which wasn't a huge surprise to me, and he had permanent epicardial leads on to see prior to seeing if his rhythm returned. And then abruptly on day 6 or 7, he unfortunately started having very dangerous looking ventricular tachyarrhythmias, some with complete loss of output and very brief CPR and cardioversion. And so I rushed him to the operating room, implanted a generator, and that actually stabilized his rhythm a great deal. But underneath this, his ventricle was globally severely depressed. It had taken a big hit in the face of the newly competent valve, which of course we all see, and we had predicted, we were concerned might happen, and that's why we had VADs to back us up. And we tried to manage things through medically for a few days, but it's very challenging when you're managing with inotropes. You actually want to try and get the heart rate down, and instead the heart rate's faster than you want. And instead we switched directions and implanted an Impella through an axillary graft in his left axilla through an 8mm graft. Very bizarre anatomy to place an Impella, but got it through the aortic valve and then rotated it round so that we were happy with the position. And this is a 5.5, and supported him with an Impella for 4 weeks while we continued rehabilitating him. He had a Fitbit on, and I'm not joking, you'd walk into the room at the end of the day to see how he was doing, and he would be beaming, and he would show his Fitbit, and he would say he's walked 5 miles that day. He was literally doing laps of the unit with this auxiliary Impella, continuing all his rehabilitation. And one of the really promising things about it is that it allows you to load with your oral heart failure medications, which we did in the last week, getting his beta blocker on board and Entresto and things like that, whilst simultaneously gradually weaning from the device slowly over a week-long period, and then removed the Impella, and he was discharged home a few days later. We've now used long-term Impellas twice, once for 5 weeks and once for 4 weeks. As I say, if you get a clean implant through an axillary graft and you're happy with the position and the functioning of the device, I think it offers very reliable medium-term support while you try to wait for ventricular remodeling or recovery. And that just shows us mobilizing him outside the hospital with his Impella in place. We again, just a few weeks ago, we submitted our recent experience with Impellas in ACHD patients to the ISHLT, so I obviously can't elaborate too much, but I will say that it's a small number. 2 of them were, for a number of weeks, and all pretty favorable survival to discharge at least. And then finally, what about very short-term or emergent support, mechanical support? And that's really ECMO. What's the role of ECMO in adult congenital heart disease? And I just want to clarify some of the terminology for those of you who are not so familiar with ECMO. If somebody has a full-blown cardiac arrest and is receiving CPR, we term that ECMO CPR. But hopefully, ideally, if you can catch them in that prodrome prior to actually arresting, we tend to call that urgent scenario elective ECMO. It's a bit of a misnomer, but that's the term we tend to use. And the third category of ECMO that we frequently use in this setting is in the operating room, where you're unable to separate from cardiopulmonary bypass, and we call that post-cardiotomy ECMO. That's very challenging because although you're not post-arrest necessarily, you're following a long pump run, severely coagulopathic, end organ dysfunction, high drug requirements, etc., etc. VA ECMO is, for me, is the most common type of ECMO that we tend to use for these heart failure patients, because it's not just oxygenating and removing CO2, it's providing full left and right heart support. But it's dangerous. There are lots of systemic complications that can occur, and it's short term, really. Beyond 5, 6, 7 days, particularly if it's post-arrest or post-cardiotomy, I start to anticipate problems. So you need to move on to your next step, whether it's recovery or some form of longer-term durable support. For me, I almost exclusively, or pretty much exclusively, use femoral VA ECMO in these patients and use a side graft. I use a 7mm side graft on the femoral artery because it virtually eliminates downstream limb complications. I'm not a fan of reperfusion cannulas and such like, and I find this is a very reliable way of supporting patients with minimal complications. We do use VV sometimes. It provides, of course, no left or right heart support. It's purely an oxygenating and CO2 removal type of support with much fewer systemic complications, and therefore can be used for a number of weeks even. For me, there are various types of cannula, various strategies for cannulating these patients. I almost always, in a critical patient, use the middle strategy. I drain the femoral vein, pass through the circuit, and then the inflow into the patient is an internal jugular inflow cannula. I find it's by far the most reliable form of oxygenating a critically unwell patient. But then gradually, as you become more stable and you're transitioning to slightly longer term support where you want to rehabilitate, wake up the patient, have them eating and drinking and potentially even walking around, I'll then switch out to an Avalon dual lumen cannula in the medium term. For all the same reasons that I discussed about transplantation and durable VAD support, these ECMO outcomes are not great. These are consecutive cases in both Toronto and Texas Children's over the last several years. And up until about 2015, the mortality was uniformly unsuccessful. Patients almost always died when we placed them on ECMO, which was a pretty bleak situation. And yet around 2015, from that time point, mortality has been dramatically less, about 1 in 3, still high mortality, but something happened around that 2015 mark. I will say this bleak picture is consistent with the published literature. There's not much granularity in these because they're both database studies, but in this, the mortality was 67% for ACHD patients placed on ECMO. And again, in this large database report, about 62%. So ECMO is collectively not a great solution. But as I said, around 2015, things did change. And yellow is the survivors and red are patients who did not survive. And since that 2015 mark, the patients who didn't survive were either extremely complex, for example, post-heart-lung transplant, or ECPR candidates. Outside those scenarios, to be honest, things have changed. From my point of view, I now expect to be able to get a patient through their ECMO run, versus in the past, one would almost anticipate not being able to do so. And we haven't got the time to go into all the little tips and tricks that we've picked up over the years, but there are many. It's meticulous hemostasis. It's really looking after the distal vascular bed where you cannulate the limb, for example. It's really trying to predict problems before they happen and preserve the end organs and avoid sepsis, these sorts of things. What about ECPR? These are the two most recent ECPR events in ACHD patients that I've been involved with, and both were unsuccessful. And that's because it is a very challenging situation. There is a lot of emotional desire to try to save these patients. For example, this is a 19-year-old who until a few days previously had been relatively well, overtly, according to their family, before a sudden atrial tachyarrhythmia prompted an arrest. And so there's a lot of pressure to try to save these patients. And this patient was extremely obese, but we did manage to get the vessels, but then could not get cannulas in. And it turned out, after the fact, we were able to dig out old catheters, which showed this patient had chronically occluded groin vessels. And of course, in the heat of the moment, you don't know that. This case illustrates the problems that these long backgrounds that these patients come with, which introduce so many uncertainties. And it's relevant because the failed cannulation is almost harder on the team than it is to actually say no ahead of time. So for me, ECMO CPR, it's not totally off the table, but outcomes are very, very concerning. And I think it would have to be a very favorable situation for us to entertain that. I'm going to finish just closing with a very recent case, which really I describe as the full Monty, because it's a patient who received all of these therapies. He's a failing mustard patient who had a cardiac arrest suddenly at work, and his colleagues immediately started CPR, and he was bundled to an adult emergency room, and they activated code STEMI protocol, which of course was unfortunate because he didn't have coronary artery disease, he has congenital heart disease. And he had a further arrest on the cath lab table, and was then bundled to us in a peri-arrest situation after 3 lengthy rounds of CPR. And he still had an output at that time, and so I did place him on peripheral VA ECMO. And over the subsequent few days, we managed to confirm that he was waking, but severely cognitively impaired, to the extent that I think most programs would probably withdraw care at that point in time. But we instead tried to give him the benefit of the doubt, and so inserted an Impella via a left, this was via a right axillary graft, and we supported him with his Impella for 5 weeks to try to rehabilitate his end organs, particularly his brain. He was in multi-organ failure with pancreatitis, liver, renal dysfunction, but during that 5 weeks improved dramatically. He was still cognitively impaired, but showing signs of recovering function. But unfortunately, his heart did not exhibit adequate recovery of function. And after a lot of discussion, we then implanted a HeartMate 3 and continued several months of rehabilitation in hospital before eventually going home. So I think his case illustrates where I think in the past, most programs, including ours and certainly most other non-congenital centers, would absolutely give up on these sorts of patients because the challenges are perceived to be too great. But I think with a really focused, dedicated team of people who live, breathe, and sleep with congenital heart disease, we can actually help these patients and get them through. Thank you very much, and we're happy to take any questions. Thank you.
Thank you, Dr. Ermis and Dr. Hickey, for a wonderful talk. We have great interest from the audience, and we're getting a lot of questions, right, Dr. McGillivray?
Indeed we are, and thank you very much. I mean, I think this has been a magnificent talk about a challenging group of patients that continue to grow in number. And as you pointed out, there are more adults with congenital heart disease than there are children with congenital heart disease. And I hope that we can meet the challenge just like our pediatric colleagues have in the last 50 years. So I guess I'll ask a question first to Dr. Hickey. It's a technical question. You talked about the use of mechanical support in patients with subaortic right ventricles. And just for the audience, I mean, there are a lot of patients out there that were treated in the 60s, 70s, and 80s with transposition of the great arteries, either with a mustard or a stenting operation. So it's a big patient population. These durable VADs are designed to go into a systemic left-sided left ventricle. They're not really designed to go into a systemic right ventricle. You talked a little bit about some of the technical challenges. So can you be specific about how you avoid the trabeculations in the right ventricle, which can sometimes lead to obstruction of the VAD?
So putting it in a normal left ventricle, you're trying to get it near the apex of the left ventricle, because we know that's away from the papillary muscles of the mitral valve, and it will keep it just slightly away from the apex so that it's not encroaching on the septum. And then once you make the ventriculotomy, you can then core out some of that compacted LV muscle to make sure it's unobstructed. The right ventricle, you're right, it presents challenges, but what I would say is there's no wrong place to put it in the systemic right ventricle, so long as it's not obstructed by trabeculations or tricuspid papillary muscles, and therefore is completely unhindered and unobstructed. And that's why I think using TEE and epicardial echo to find that best location is your friend. So we have TEE probe down, and just with your finger you can compress on the free wall of the right ventricle or the diaphragmatic surface of the right ventricle to find an area where you can see your dimpling finger is not obscured by, for example, a papillary muscle. And then once you've chosen your location, you then use an epicardial probe in that exact spot. So you're looking, the window you're looking at is the exact path that the inflow cannula is going to take, and you can see whether there's a tricuspid papillary muscle in your way or not, and adjust accordingly. And once you've found your location, we core out the ventriculotomy, and there's lots of heavy, thick, overgrown RV trabeculations, which you can core out at your leisure, so long as it's not a papillary muscle, and you can core out a lot of muscle. And taking that approach, we've never had a situation where we've either had inflow obstruction or had to reposition the sewing ring either. So that's the way that we've done it. And as I said, it usually sits either in a funny sort of anterior position or on the diaphragmatic surface a little way away from the apex.
And then just an additional question, rather than a technical but a physiologic question. I know that certainly, I think there was a report out of the UK a few years ago about the surprising challenge of supporting the subaortic right ventricle, that you would think that the robust morphologic left ventricle, the subpulmonary ventricle, would be just fine, but there's a number of patients that go on to develop biventricular dysfunction after the systemic RVAD is put in. Has that been a problem for you, or how have you avoided that problem?
That's not been a problem for us, actually. It can be occasionally be a problem for these patients when they actually present with very high PA pressures. You can have some degree of LV dysfunction, which is in fact why, in terms of your options, you've got a subaortic RVAD as one option, mm-hmm. High-risk transplantation as another option if they've got borderline elevated PA pressures. Your third option, which we hadn't mentioned, is a late takedown of your atrial switch and a conventional arterial switch, so a mustard takedown and switch, which we in Toronto, we did actually discuss several times, and we'd done 3 times. All 3 survived lengthy periods of time, in fact. So it's not something to be discounted, but it is a fairly unappealing strategy because the left ventricle, as you point out, can fail. I've not had problems where the left ventricle fails after the RVAD has been put in, and instead we've seen the opposite in that the PA pressures come down to the extent which theoretically should help that left-sided ventricle to the extent that we can then discuss possible transplantation.
Okay. I have another question for both of you. What are the medical and surgical challenges of the management of a VAD in a single ventricle?
The medical challenges of VADs in single ventricles.
Right, medical and surgical challenges of the management of a VAD in a single ventricle.
So there are considerable surgical challenges of VADs in single ventricles, which I think can be lumped together with other high-risk operations on single ventricles, whether it's Fontan conversion, Fontan revision, or Fontan transplantation. They all come with the same challenges. One is the fact that they're profoundly vasoplegic. Their endothelium is chronically sick and simply doesn't work, and you often come out on extremely high doses of vasopressors at the end of all of these types of operations. And it's one of the reasons why I am strongly advocate very early extubation in these patients, because it fixes so many problems. If you keep these patients asleep, I see it as 2 windows. You either have a window to extubate very early, and for me that's within 48 hours, or you're going to miss that window and you almost expect that patient to be intubated for 10 days or so, by which time they'll be delirious with multi-organ dysfunction, and it's a very guarded situation. So early extubation is a key strategy to try to break that cycle of vasoplegia and delirium and such like. I won't go into all these sort of anatomic challenges of these single ventricle operations, but post-operatively, another key thing with managing the VADs is anticoagulation. There's a perceived risk of greater thromboembolic problems. And switching to the use of bivalirudin, I think, has been a very successful strategy, really pushed forward by Texas Children's that we learned from Texas when I was back in Toronto, and here now seeing it much more ubiquitously. It is a very effective way. The stroke rate is much, much less before you transition to warfarin. So I think that's another key important feature. I don't know if you had any other comments.
Yeah. So I think the one thing that I would say when looking at these patients with single ventricles is you can't just focus on the heart. Fontan patients are a truly multi-organ, whole body disease. So most of these patients have lived with that for decades. And so just by changing their cardiac anatomy and physiology, you're not going to revert much of what's already been done from that whole decades of multi-organ failure. So you do have a high risk of issues associated with their kidneys, liver, that you have to have a very high index of suspicion and want to be aggressive in trying to manage those patients. Sometimes you may need hopefully short-term dialysis for those patients who are kind of borderline from a renal perspective going in. So you hope to avoid needing anything long-term, but you really do have to take all of their organs into account. And you don't want to ignore that and just focus on the cardiac aspect.
So in that vein, or staying on that topic with the failing Fontan, I was fascinated to hear earlier on about your comments about the degree of liver dysfunction. So many of these patients do have, or all of these patients have some degree of congestive hepatopathy, but some do go on to develop actual cirrhosis. So how do you evaluate the liver, and how much liver disease is too much liver disease in terms of just transplanting the heart as opposed to going on to a heart-liver transplant?
We got cut off for a second, so I didn't hear the beginning of your question. It sounds like it was in the case of Fontan patients, heart versus heart-liver. What's liver? What do you need to do from a liver perspective?
Yeah, we're constantly having to make an assessment of how bad is the liver disease. So how bad is too much? How bad is okay to just go ahead with a heart transplant?
I think if you ask, 5 different ACHD people, you probably get 5 different answers in that regard. I think from our perspective here, we've been, very tolerant of liver disease in a way that we don't. Very rarely do we feel that we have a need for a dual organ transplantation. I think there are specific reasons for that. I think you have to take into account what you see when looking at the liver, but I think you also have to take into account what you see from a patient perspective. There are we probably follow adult-wise, 120, 150 Fontan patients that we kind of keep an eye on, and many of them have liver dysfunction and liver disease, but only a handful have actually truly, manifestations outwardly of whether they have recurrent ascites requiring frequent paras or other manifestations of severe liver disease. I think those typical subsets are ones that may need to be addressed. And then obviously those patients who have a high suspicion or a diagnosis of hepatocellular carcinoma, right, that you're trying to explore liver transplant in a Fontan and needing a liver and a heart at the same time from that perspective. If Ed has any additional comments.
I'll just elaborate on that because it's a very hot topic, and there are two schools of thought. One school of thought is that the liver is clearly fibrotic or early cirrhotic, and therefore there's a rationale for undertaking combined dual organ transplantation. The other camp takes a view that actually the liver appearance, both macroscopically and histologically, is more alarming than it physiologically actually manifests in the perioperative period, and therefore just proceed with heart transplantation because the overall impact or risk is lower. I'm in the second camp of that, and in Toronto we never undertook combined dual organ transplantation in this setting, and I never had problematic perioperative liver dysfunction that was to a life-threatening degree. It was always transient in that setting, and yet other schools, other camps have series where they almost uniformly undertake heart liver transplantation. For me, it's just not necessary. The exception is hepatocellular carcinoma, and we did assess one patient who had recurrent hepatocellular carcinoma for that reason, and we didn't want to undertake just liver transplant in the face of a Fontan. So for me, in terms of biomarkers, the albumin and synthetic function is the most important. Even if the transaminases are mildly deranged, if the albumin is reasonably normal and other synthetic biomarkers are okay, then that's for me a reassuring sign. The exception is PLE, and you will occasionally have patients with marked ascites, intermittent, very low protein levels, and we've transplanted them, and their PLE takes considerable time to gradually resolve, but it is reversible.
So just to push that issue just a little bit more, so if on liver biopsy there is stage 4 fibrosis and frank cirrhosis, not a problem?
So I think obviously it's a spectrum, and most failing Fontan patients have established fibrosis with early signs of cirrhosis, and if you have that picture with reasonable albumin and other reasonable synthetic function, I would proceed with heart only. If you've got full-blown extensive cirrhosis with other features of really very limited hepatic reserve, we would take that much more seriously, and that might be.
Thank you.
I think that covers most of my questions. I have one more. You mentioned the HeartMate 3 pump. Is that the pump that you use most of the times in these patients, or you're using any other pumps?
So no, most of the time we've used a heartware, the HVAD, and of the cases that I described both in Toronto and the Newcastle groups ones, they were all HVAD as far as I'm aware in Newcastle too. Of course, the HeartMate 3 is a newer device, and we used our first one last December in an adult congenital heart disease patient with CCTGA. And I must say, although the controller is less intuitive because you don't have the waveform, and you rely instead on just raw numbers, so the controller interpretation is perhaps less ideal. The device as a device, I think, is excellent, and so we're increasingly using that as our default.
Thank you, Dr. Hickey. I think those were all my questions. Did you have any other?
Terrific. No, this has been a great hour, and thank you very much to both Dr. Hickey and Dr. Ermis for a very provocative and exciting talk. Thanks to the audience for joining us this morning, and to all of you, stay safe. Thanks very much.
Thank you.
Thank you very much.